All right. So welcome to the first ever journal club that you're involved in, because Matt and I have totally done a 1 HP journal club that was just the two of us before. But this is the one that you're involved in, which makes it new and exciting and different.
Yes, it is.
So for people who don't know, the goal of a journal club is to critically assess a piece of research available to us, to make critiques of method, of the analysis, if appropriate, to draw what conclusions we can from it that are applicable to our own practice, and then to propose some ideas for further research and see what else is out there kind of in this vein and on this topic, because it's probably useful and valuable to us if we're bothering to read it in the first place. This time specifically, we are looking into blood flow restriction. This research article is entitled The Effect of Eccentric Exercise with Blood Flow Restriction on Neuromuscular Activation, Microvascular Oxygenation, and the Repeated Bout Effect. And for anybody who did not take a metric butt ton of Latin or large amounts of medical classes, that kind of just looks at doing a certain type of exercise where the muscle is lengthening rather than just shortening. So think about the lowering portion of a bicep curl so that they're raising it. Looking at how blood flow restriction can be incorporated into that type of exercise. And blood flow restriction is more or less applying a tourniquet or reducing blood flow to a small area for a short period of time. Don't attach tourniquets to your legs while you do leg day, kids. That's not the point of this article. And then it was looking at how well the nerves tell the muscles to do what they're supposed to do, how much the blood vessels local to the area are getting oxygen to use to the muscles, and also looking at the repeated bout effect. And the repeated bout effect is... Actually, Elliot, why don't you tell us what the repeated bout effect is, because you're the one who read this.
Yeah, so the repeated bout effect essentially is an effect where you perform one of those eccentric exercises that Caitlin was just talking about, where you're slowly lowering a weight down through a range of motion that a joint is capable of. And if you perform this eccentric action, I think a lot of the studies that looked at the repeated bout effect looked at 14 days prior to the maximal eccentric contraction. So you do a lower level eccentric contraction as kind of like a motor priming. They don't really have a lot of good mechanisms in place yet for why it's working. It's a combination of neural, mechanical, or cellular responses that are sort of responsible for it. But essentially, you do the same type of movement that you're planning on doing with a heavy weight, that eccentric activity, before you do it, and then when you go to do it for real, it is actually it causes less muscle damage and pain and decrease in function.
That was an excellent summation. Good job. So in this particular article, we're going to kind of break down how they studied what they studied, what they figured out from it, whether or not we can use it, and why or why not. And where do we go from here? Somebody is welcome to bring in the next line of the Blink-182 song. Great. So starting at the beginning, what was their kind of stated objective with this research?
So they really wanted to look at how low-intensity eccentric contractions with and without blood flow restriction and the effects that particular training protocol had on A, microvascular oxygenation, 2, neuromuscular activation, and 3, the repeated bout effect. So to kind of break that down a little bit more, the eccentric contractions that are usually done to elicit the repeated bout effect are usually a little bit higher, somewhere between 40 to 100%. This one looked at a low-intensity eccentric contraction with the BFR cuff on. And BFR is typically done at a low intensity, about 30% of maximal 1 rep max contraction. And because of the lack of oxygen to the area and the pressure caused by the occlusion of the venous return, so that's the blood flowing out of the arm or the leg, depending on what you're looking at, you actually see increases in metabolic products, neural activity, and you don't see increases in muscular damage with low intensity activation there.
All right. So how did they set this up to look at that specific thing, to look at how low-level eccentric exercise with or without blood flow restriction, how it affected those 3 specific domains? How'd they kind of...
So they used a randomized control trial, which is one of the best ways you can kind of assess how independent variables affect a dependent variable, and that's things you can change and basically people's response to it. So they set it up that way. They had 24 participants in this study, which isn't a huge sample size. And some of their design in this study was not what I would call amazing. They really didn't define who was in this study, and that's really important when you're going to try to make characterizations of populations based on who is actually in the study. The fact that they didn't define that really kind of undermines a lot of what they did here. But they did define their exclusion criteria, so they didn't look at anyone with metabolic conditions, pulmonary conditions, cardiovascular disease, and an orthopedic injury within the last 12 months. Before the participants participated in the study, they were asked to refrain from any unaccustomed strenuous physical activity, maintain their normal dietary habits, and not take any anti-inflammatory drugs or nutritional supplements during the experimental period.
Okay. How were they picked? Did they just, grab random people off the street? Did they have volunteers for the study? How did they choose these specific 20?
We have no idea because it wasn't defined.
Yes, and so that is a bit of a concern. So tell me, why is it a problem that they didn't explain?
Because the sample size could be anybody. It could be geriatrics, it could be pediatrics, it could be men, women, it could be ages, all ages. There's no generalizability with this population because we don't know who they are.
Absolutely.
We don't know if they're trained athletes. We don't know if they're untrained. They said they were refraining from usual exercise. What was their usual exercise? The repeated bout effect doesn't really have as significant of an impact in well-trained athletes. So it's kind of up in the air as to who we're looking at here.
And that's right. You're right. That is really, really relevant, and really kind of gives us a bit of a caution about what conclusions we draw from it in terms of how we'd put it into our practice. It's also useful to consider for other studies that if you're not getting kind of a definition of how you got the population that you did, it may be that it was a random sample population. Maybe they did do a great job of kind of just, took some random people. Or maybe it's, this is a certain research professor's class and all of the people who are being studied are students in his class, which means they're all probably within one major. Maybe it's paid volunteers. A lot of times it's definitely hard to get people to do things for free. But if you are paying people to participate in your study, that should be disclosed, especially when it comes to psych studies, not just PT studies. So that kind of lack of information is a little bit unhelpful. And that gives us kind of just a slightly different lens to view what results we get through here.
Right.
So how did they, with kind of not having explained who their population was, how do they try and make sure that population was distributed well and that they weren't going to be biasing their own results?
They did random allocation for the different participants into groups. So at least they mentioned the randomization there. They get a point for that. But there was no blinding discussed. And like you said, if these participants were being paid or compensated in some way, they may be trying to perform better for their evaluators, and that can definitely impact bias in a big way. So there's really a lot of hazy information here. So
why might it be difficult in general in PT research to do blinding?
You definitely have a fairly good idea of what kind of intervention you're going to get. It's hard to do a sham blood flow restriction intervention where there's no pressure being applied. So yeah, I mean, you will definitely see those types of biases associated with that, just because it is difficult to.
And let's think about it from the other side of things too, because it is possible to do even mock dry needling or to do mock massage, like soft tissue mobilization. But it's definitely tough to do a good double-blind study where not only do the participants not know which kind of whether test treatment or control treatment they've been assigned to, But it's really not terribly possible to blind a physical therapist to which kind of treatment they are performing. So there's no way we could possibly blind the PT evaluators involved here as to whether or not they are actually applying blood flow restriction or not to their own patients.
Right.
All right. So how did they do their follow-up? Kind of what measures did they look at to assess the data they were looking for?
So they looked at measurements that include range of motion, thigh circumference, muscle soreness, and maximal voluntary isometric contraction, as well as visual analog scaling for all of the groups at the lab, 24 hours, 48 hours, 72, and 96 hours after they performed the maximal eccentric exercise. These measurements are all kind of indicators of exercise-induced muscle damage, and that's what the repeated bout effect is actually supposed to attenuate or decrease there. So it makes sense why they would take those measurements. I think some other measurements could have been included in this, but we can talk about a little bit more about that later.
Okay. This part is a little bit less kind of specific to PT stuff, but this is really important when it comes to critically assessing data. How did they analyze the data, and did they choose an appropriate way to do it?
So they used a two-way analysis of variance with a one repeated measure, and they used that pretty much for both of the data sets that they analyzed there. They did some post hoc analysis, and that was in fact the appropriate method. A two-way repeated measures ANOVA is often used in studies where you have a measured dependent variable over 2 or more time points, or when the subjects have undergone 2 or more conditions, being time and the conditions that they were evaluated under. And the whole point of the two-way repeated measures ANOVA is to understand that there's an interaction between those variables. So it was appropriate, the method that they used for this study.
All right, absolutely agreed. I was also very impressed with how you detailed how two-way ANOVA works. Good job. You're making my geeky data science. All right, so we said kind of earlier on that their objective was to look at performing low-intensity eccentric exercise with or without blood flow restriction and see how it affects 3 different factors: oxygenation in the local region, activation from the nerves to the muscles, and the repeated bout effect. What did they find?
So as far as microvascular oxygenation goes, they actually did find that there was a greater increase in the deoxygenation content. So there was greater deoxygenation for both the low-intensity eccentric BFR as well as without the BFR. And this has kind of been confirmed by a lot of other studies. So they really didn't tell us anything we didn't know there. As far as the neuromuscular activation goes, they looked at the EMG data that they collected on they looked at the quadriceps muscles. So they did see that there is significantly greater neuromuscular activation in the BFR group compared to the low intensity group. And that's also what we kind of would expect to see with BFR training, as confirmed by other studies as well.
Why would we expect to see that with BFR more so than without BFR?
It's a great question. So BFR has shown to have these kinds of neuro effects. And honestly, I'm not entirely sure why. Yeah, I'm not entirely sure
that's
why.
fair. I don't know is a perfectly valid answer, and I want more people to give an I don't know answer sometimes. This is actually something that's kind of still up for debate. Like, they're trying to figure out the exact mechanism. Currently, the best proposed mechanism that I've heard and read about is that you're basically fatiguing your fast-firing muscle fibers, your type 1s first. And then as those fatigue, you were recruiting kind of your slower twitch muscle fibers, which means that, of course, over time, you're going to have activated a higher percentage of the total muscle fibers you have available in a region. And that as you further exhaust those muscle fibers, your body is kind of realizing that it's out of muscle fibers. It then kind of concludes, oh, I need more muscle fibers in this area, which should then promote muscular growth kind of down the line with, repeated uses of that BFR. That's the proposed mechanism for it.
Okay.
That's the proposed mechanism that I've heard most frequently, and the one that passes the sniff test. It seems plausible.
Yes, they did mention that in the study, and also I just recalled that I've read several articles that show that BFR actually does have effects on corticomotor excitability as well. So the actual part in your brain that's responsible for stimulating your muscles via the nervous system actually becomes more excitable with blood flow restriction. And that's kind of a chicken or the egg thing. Either it's because of what you said, that you do need to have greater coordination when you're only firing on a couple cylinders with all the other oxidative muscles not in the picture, or the aerobic muscles not in the picture, or it actually does the hormonal change, or the hormonal change in the blood actually affects the brain to produce more of this kind of corticospinal response.
Yes, and whether it's the chicken or the egg, the end result is that we get more activation with the BFR than we did without, which is borne out through other research. All right, and last but not least,
can I pause this for a little second?
Yes.
I really am just super interested in this exact application for tendinopathy, right? Because
that as well.
There's not all that much research out there. Because that was one of the first things I asked my coworker when he first started explaining BFR. There's a couple people trying to study it right now, but there's not any actual existing research yet. However, it's certainly proposed that this would have a positive effect on tendinopathy. Because one, you're increasing motor recruitment, but two, you're also increasing local oxygenation, which should promote improved healing.
Mm-hmm.
You're also stimulating human growth hormone as well as insulin-dependent growth factor. So those are all part of the building blocks for protein, as well as collagen synthesis with growth hormone. So
I just thought that was super interesting.
That have been proposed out there for tendon healing, but right now all we have are a couple shoddily put together case studies.
I just think it's interesting, right? Specifically with that Rio study that I reviewed with TNT, where she talks a lot about corticospinal excitability and how that's an influencing factor of why there's a reduction of pain with isometric protocols in tendinopathy. So they say that, right, with isometrics, it increases corticospinal excitability. But if we use BFR in addition to that, we might be able to see some really, really positive benefits in terms of reducing the time of recovery. So
I've actually been doing that in the clinic using BFR with the Rio.
Nice.
Protocol. I've been just
nice.
You might be able to, Elliot. You might be able to get a case study out of that.
Maybe if I had maybe 24 more hours in a day.
Yeah, I know that feeling. That's fair. You are understandable.
Anyway, sorry for pausing you guys.
That's okay.
You guys can go on.
All right. That's fine. So, based on there's the kind of conclusions that they drew. Actually, let's state their conclusions first. What were their conclusions?
Okay, so basically the study concluded that BFR with the eccentric, low-level eccentric activity was really not more effective than just doing low-level eccentrics for attenuating that muscle soreness that you experience after a heavy load of eccentric exercise. But they were both effective, so it's not like you're doing any harm by applying the blood flow resistance, and you may be getting some of these ancillary benefits as well. But I really wish they had looked at more of the ancillary hormonal responses in the blood compared to just the oxygenation, what they looked at. But anyhow, sorry, that's for later.
Okay, so are those conclusions that they drew that low intensity eccentric exercise with blood flow restriction is no more effective than low intensity exercise without blood flow restriction at decreasing muscle soreness after eccentric exercise? Is that justified based on the data that you?
I think based on the information that they gathered, even if it wasn't very well put together, as far as defining populations and stuff, I do believe that it was justified. Yeah.
I would agree. So do we think those results are generalizable? Do we think that we can say to a greater population that for everybody, this is how it's going to work, that low intensity eccentric exercise with blood flow restriction is not more effective?
Heck no,
Excellent answer. Why not?
because they didn't define the populations at all. So you can't generalize it to anybody.
Yes, we can't specify or generalize this particular piece of data because we don't actually know who the patient, who
I feel
the
like that's
participants.
yeah, I feel like that's the main theme that I just kept drawing from all of these. It's just like, well, I don't know who this is about. I don't know who this can help, but cool study.
I will say, though, that I really did like that they reported a negative result. That is, showed that blood flow restriction didn't do more when it came to one of their measures, whether or not it affects muscle soreness. Because a lot of times negative results don't get published. So it's really helpful for this kind of work to get published so that people then know, like, oh, all right, we don't have to go keep, chasing after the same wheel. We already know the answer here. So what can we draw from this to use clinically with our patients?
I definitely think that you should not use BFR if this is the only thing that you're trying to accomplish, is that kind of attenuation of exercise-induced muscle soreness. I think that BFR can be useful for other things that the study did show. It does, as far as the metabolic and the vascular changes. But yeah, I think it's not an effective method to modulate pain associated with muscle soreness.
Okay. Who do you think you are most likely to use blood flow restriction training with?
I think blood flow restriction training right now is really useful for post-surgical populations, untrained populations, the elderly, people that can't do high load exercise to kind of preserve their muscle mass and increase their metabolic demands. So those populations are currently the prime candidates for BFR. And especially if you're introducing new exercises that may be higher load than they're used to, using something like a low-level eccentric before you do that may be beneficial.
Okay. Let's see. Do we think there's any valuable in using this for more trained populations? You referenced a little bit earlier that that repeated bout effect is a little bit decreased in trained athletes. Do we think that blood flow restriction has any value there?
So they made recommendations based off of some other studies that you can kind of periodize blood flow restriction with your typical strength training, and you can kind of see a increase in hypertrophy with that. I don't have the exact citation on that, but they did make that statement in the paper based on some of the other data. So I think that's an important thing to look at. But the big thing with BFR is that you're not loading the tissues maximally. So you're not getting a real good mechanical transduction of force through the actual collagen fibers that compose the myotendinous unit. So the tendons that connect the muscle to the bone are not being stressed properly. So if you're going to jump back into high resistance training after incorporating BFR, you may see some damage that's actually done to those tendons, and that could be up for debate whether or not that damage and cyclically loading it with BFR and resistance training could actually be beneficial for tendon structures. But I think precaution should be used there when kind of cycling.
Okay, so what I'm getting from this is that you're suggesting part, not whole. That is, BFR could be part of a good training or rehab program, but it should not be the primary or sole component.
I would agree with that statement, yes.
All right. So this is the part that I can tell you're very excited for because you wrote a lot of things under it, and I'm very proud of you for that. What kind of things what could this study have done better? What were the shortcomings?
So the shortcomings as reported by the study is that they used deoxygenated blood instead of looking at the oxygenated blood. And this could have potentially been affected by a change in the blood flow, which was not investigated in the current study. So they didn't actually take like a Doppler ultrasound and see how much blood is going in and out of the muscles during contractions. So they really weren't selectively measuring the pressures that they used weren't selective enough to really ensure that they were getting the deoxygenation that was reported. I think that other studies that look at BFR training use values of about 150% to 200% when doing this to kind of mitigate that, and they used a 130% occlusion for systolic blood pressure. So I think that playing around with the occlusion pressures, if you're not going to use that Doppler, could have been incorporated here from what I'm getting from their reports on their limitations.
Okay.
They also looked at relative eccentric intensity that was different from previous studies. They based it off of the eccentric one rep max. Sorry. This is based on the eccentric training intensity on concentric one rep max, while the present investigation based eccentric intensity on maximal eccentric torque capability. So they looked at actually how much are you able to generate eccentrically through the range as opposed to looking at a concentric one rep max. They actually saw better results in this other study that looked at the one rep max concentrically. So that was different from a previous study, but it is an important consideration as exercise intensity has been reported as an important factor for BFR training induced muscle hypertrophy. They looked at 30%. I think I mentioned that most studies look at 40 to 100%. So maybe they would have seen different results if they had used a higher percentage of that maximum eccentric torque capability. At least 40%, I think they should have used. Sorry if that was a little bit rambling.
Totally okay. Anything else that either they reported or that you thought was a bit of a problem with this?
So things that I saw as shortcomings of the study, they definitely needed better definitions of the study population, bias, the stuff that we had talked about. I would have liked to see some functional outcomes paired with the visual analog scale of pain. The visual analog scale can be very biased based on the person's perception of pain, and also rate of perceived exertion also has a big impact on the visual analog scale for pain. So how much you perceive that you're working during an exercise will actually change how much your perception of pain is there. So I think they should have taken two separate measurements for that, as well as looked at something like functional squatting. Is it easier, harder after they did this at the intervals that they looked at, the 24, the 48, the 72, etc. I also think that they should have looked at some different types of measurements to actually see if there was any muscle damage done. A lot of these metabolic factors that are kind of easy to measure via blood tests, like creatine kinase. They talked a lot about heat shock proteins in the actual introduction to this as a possible mechanism for these metabolic changes, and they never actually looked at how those heat shock proteins are affected by BFR. You could look at blood lactate levels to see if those are increased, because those can stimulate kind of these metabolic changes that we see. There's things that they could have looked at to kind of make this a little bit more physiologically applicable, and I think they kind of missed the boat by only looking at basically oxygenation and EMG. I think they could have done some blood testing that would have made this a lot better.
Okay. So it sounds like you've got some things that you would have liked to see in the new. Are there kind of other things that we can build off of or take from the study, and then kind of move forward with other ways of kind of looking at BFR and its applicability to our use of patients?
So I would like to see different methods of contraction assessed here. They looked at low intensity eccentric contraction. There is actually another study that I went and found that looks at high intensity eccentric contraction, and they found completely opposite results, that it actually does attenuate the pain of doing maximal eccentric contraction. They looked at 130% of a one rep max concentric contraction with an eccentric contraction and BFR, and they found that it actually does reduce the soreness found after. But that study has its flaws as well. They used the people that did the participants, they used themselves as the controls from one arm to the next, and it had a lot of issues with it there. So I would like to see that explored a little bit more for sure, because I think that there is some promise to using BFR, because it's still so new and so unexplained in its mechanics. I think that there's a lot that you can do there. It would be interesting to see if they could selectively isolate the type 1 fibers versus the type 2 fibers, see if that fatigue is really being correlated with the neuromuscular changes that we had talked about there. There's a lot you can do here, and I would really like to see more done.
And Matt, it sounds like you'd really like to see some more research done on BFR with tendinopathy.
Yeah, I think that's the number one thing I'm interested in. And I guess as a final question, do you, Elliot, see any relevance to esports and how it can be used?
Definitely a lot of esports participants are going to be your untrained athlete as far as a traditional sports perspective goes of strength and resistance training. So if you can kind of ease them into it by attenuating that delayed onset muscle soreness that you see, you could definitely get more buy-in from the athlete. And also you can make changes quicker if you're able to improve because all of these exercise-induced muscle damage comes with all these range of motion strength limitations. You can actually progress them faster through protocols if they're able to lift more, faster, better, stronger.
Yep, that's what I'm totally interested in. So
I think that's a good conclusion to draw. So it sounds like there's some stuff we want to explore with this, which is why it's great that I'm going to try and take a blood flow restriction training course and get certified in September.
Oh yeah.
Yeah, there's a course pretty near to me. Actually, you might want to look into it if you're on the East Coast in September.
I am not.
Okay, then you should not look into it in September. You should instead focus on your clinical rotations and look at doing this some other time. I do think another thing that might be valuable for our esports clients is that blood flow restriction it's kind of cool and new right now. It's the kind of thing that isn't traditional. It's a little bit out of the norm and draws some attention and some interest. I think that in medicine, a big part of, and actually not even I know that in medicine, a big part of how well our patients recover is how much they trust us and the kind of rapport that we develop. And so if we're offering a new technology that they're buying into, that we then are able to back up with research and say that, hey, this does have value. Hey, this does have these effects. I think we're also more likely to get that kind of buy-in and that rapport that leads to way better patient outcomes.
I agree completely. I think in our field, we see a lot of these fad modalities come out, and they kind of take a big sweeping effect over the entire community. But fads equal funding. So I mean, if we can get a lot of people interested in it, and we can kind of really explore what its uses are, I think there are some benefits to that kind of fad status that it has. We've seen this a lot in different.
I think dry needling is one of the biggest ones we've seen it with.
Yeah.
And Graston 5 years ago.
Oh yeah.
IASTM for sure.
But a lot of research came out of that, and we know more about it now.
Yeah.
So I mean, I don't think it's a bad thing.
I don't think so either.
Just make sure when you get a hammer, not everything's a nail. That's
exactly
nice. Nice one.
That's a really good way of looking at it. And I think on that note, we are going to wrap for the night.
Alrighty then. Thank you guys.